A very good afternoon to the esteemed audience listening to this presentation, and I am grateful for the opportunity to present the study on behalf of my team members. The topic of my study is quadratus lumborum block versus transversus abdominis plane block for post-cesarean analgesia, a randomized prospective controlled study. Cesarean deliveries are usually associated with severe postoperative pain, hampering early mobilization, early breastfeeding, and emotional bonding with the newborn. Multimodal approach to management of the pain is the answer, and several regional blocks form a part of this approach. TAP block was first described by Rafi et al. Using a blunt needle and a POP technique. In 2007, Hebert et al. Introduced the ultrasound-guided method. At our center, where the study was conducted, bilateral TAP block was regularly being used for providing post-op analgesia for LSCS patients. However, we noticed that the patients were requiring analgesia after 7 to 10 hours with the requirement of additional either opioids or NSAIDs. So we tried to hunt for a newer block which would answer the question of inadequate analgesia. QL block was the new kid on block, and we wished to compare the two blocks in search for a more prolonged and better analgesia for our LSCS patients. The aim of the study was to compare the effects of ultrasound-guided QL block versus TAP block for postoperative analgesia in cesarean delivery under spinal anesthesia, with the primary objective of measuring the time to rescue analgesia and the secondary objectives of measuring the total duration of block in both the groups, the number of patients requiring rescue analgesia, and the total amount of rescue analgesia required in each patient. The study was conducted at a military hospital between July to September 2019. After obtaining due approval from the Ethics Committee and registering the study with CTRI. All patients undergoing LSCS in the age group of 20 to 35 years in ASA 1 or 2 were included in the study. The sample size was calculated based on the study of Yusuf et al. With an alpha error 0.05 and powered 80% and was found to be 36 in each group. So we included 40 patients in each group. As far as the study protocol is concerned, all patients were explained the procedure and written informed consent were obtained from them. They were also informed that refusal to participate will not impact their standard of care in any way. All patients underwent careful evaluation preoperatively. Once the patients were taken inside the OT, an IV line was established and co-loading was started with 500 ml of ringalactate. Baseline parameters were recorded and standard monitoring was instituted. After the subarachnoid block was performed in this left lateral position, the patients received injection paracetamol 1 gram IV and diclofenac suppository 100 milligrams immediately after surgery as part of the anesthesia protocol. Both the blocks were performed with the patient in the supine position immediately after the end of the surgery using the linear probe of edge ultrasound system from Sonosite. For the TAP block, as I will be showing you in the next slide, we place the probe in the anterior axillary line between the thoracic cage and the iliac crest at the level of the umbilicus. The three abdominal wall muscles were visualized clearly. The target was the plane between the internal oblique and the transversus abdominis muscle. The needle was inserted in plane. As you can see the needle here, inserted in plane, directed towards the fascia between internal oblique and transversus abdominis muscle. And after careful aspiration, negative aspiration, 20 ml of 0.25% bupivacaine with 4 mg of dexamethasone was injected, looking for the typical spread of the drug, the kayak sign. The procedure was repeated for the other side in a similar manner. There is a small video which is showing the needle very clearly trying to approach the plane between the internal oblique and the transversus abdominis muscle and injecting the drug in the plane between the two muscles. For the quadratus lumborum block, we placed a wedge beneath the buttock to have a better probe movement with patient in the supine position. The ultrasound probe was placed at the level of the anterior superior iliac spine, and then it was moved cranially until all the three layers were identified. The external oblique muscle was followed till the visualization of the posterior border of the muscle, as I will again show you. This is classically known as the hook sign. So the needle was introduced. As you can see in this slide, the three muscle layers, external oblique, internal oblique, and transversus abdominis, and the external oblique curving like a hook, which is known as the hook sign. The merging of all the fascia with the fascia over the quadratus lumborum, and this is the place where the drug is injected, and we can see the spread of the drug under the ultrasound guided block. This is a small video showing you the approach of the needle, and as you can visualize, the needle is approaching the junction of the fascia over the transversus abdominis with the fascia over quadratus lumborum, the hooking of the external oblique, and the merging of all the fascia. This is the point where the needle has reached, and the drug will be injected at this place. For the statistical analysis, it was performed by using SPSS version 2.0 statistical software package. Data were expressed as mean plus minus standard deviation, frequency, and percentage. Qualitative data was analyzed by using independent sample median test and chi-square test. Quantitative data was analyzed by using sample t-test, and p-values less than 0.05 was considered to be statistically significant. As we can see from the demographic data, there was no statistically significant difference between the two groups regarding the age, ASC status, and operative time. Also, as we can see, the indication for the surgery has been tabulated and grouped into elective and emergency. In both the groups, we can see that the commonest indication for post-LSCS was for post-LSCS pregnancy in both the groups, and for planned surgery, and non-progress of labor for emergency surgeries. So there is no difference between the indications for surgery in the two groups. As far as the results of the analgesic effect of both techniques is concerned, it is evident that the time to rescue analgesia was more in quadratus lumborum group than in the TAP group, with a mean of 1353 minutes in the QL group as against 915 minutes in the TAP group, and this difference was statistically significant. As seen in this table, only 6 out of the 40 patients required rescue analgesia in the QL group, whereas in the TAP group, 31 out of 40 patients required rescue analgesia, and correspondingly, the amount of analgesics that was required was significantly different. This is a graphical representation of the VAS scores in patients in the two groups. The blue line indicates the QL group and yellow line indicates the TAP group. As we can see that up to 6 hours, almost 6 hours post-operatively, there was no difference between the VAS scores. However, it started rising in the TAP group thereafter, and by the time it reached 22 to 24 hours, again the difference ceased to be statistically significant. So to summarize, there was no significant difference in demographic variables. The time to rescue analgesia was significantly more in the QL group. VAS scores for pain was significantly higher in TAP group. Duration of post-op analgesia was shorter in TAP than in QL. And requirement of rescue analgesia is significantly higher in the TAP group. There are various modalities to control pain in LSCS patients which are in vogue. Most commonly used are opioids, NSAIDs, epidural analgesia, and each of them has its own limitation. A recent review article mentioned intrathecal opioids as the gold standard, but troublesome side effects have led to the search for the ideal option in terms of simplicity, safety, efficacy, and prolonged duration. And that is how regional anesthesia techniques came into vogue. So regional anesthesia, however, is not effective alone as much as a part of the multimodal technique. Now, as for TAP block, it provides good somatic analgesia by blocking the thoracolumbar nerves T10 to L1. However, the duration of action of TAP block as far as providing analgesia was concerned was limited, and so the search continued. As QL block was first described by Blanco, and it is presumed to provide extensive analgesia from T7 to L1 dermatome with a spread of the local anesthetic along the thoracolumbar fascia and the endothoracic fascia into the paravertebral space, thus providing somatic as well as visceral analgesia. In our study, the mean time for rescue analgesia for TAP block was also more than some other previous studies, probably because of the use of dexamethasone as an additive. And though the results of our study were same as many other studies which have been done, a few other studies that have been done, especially by Blanco and Yusuf et al., who have compared the two techniques in lower abdominal surgery, but we studied the effect only up to 24 hours. However, there has been a recent study which has studied the effect beyond 24 hours and has found prolonged analgesia up to 72 hours in the QL group, probably due to the more posterior approach that they have used, as the QL block has many approaches. However, the approach that we have used is simple, easy to perform. Patient does not have to change her position at the end of the surgery, and it is very safe, and all the layers are clearly visualized, and it is totally under vision that this block is being performed. The limitations of our study is that we did not assess the post-op dermatomal levels of the block as part of our measurements. We did not study the pain scores in emergency and planned cases separately, and we did not study it at rest and at movement separately. However, these are food for thought and maybe can be evaluated by some other studies in the future. To conclude, bilateral quadratus lumborum block provided more effective postoperative analgesia when compared to TAP block in patients undergoing cesarean sections. And proper implementation of this technique can actually reduce the use of opioids after cesarean sections. And it has formed a standard of care for all our LSCS patients undergoing surgery and as part of the multimodal pain therapy for them. I wish to thank the audience. I wish to thank all the team members who worked on this study. Special thanks to Colonel Krishna Prasad and Colonel Vipin Sharma. Also to Major Mallikarjun, who helped me with the statistical analysis. All the ORAs, the nursing officers who helped in gathering the data and caring for these patients. And last but not the least, the patients themselves who agreed to participate in the study. Thank you all.